The combination of Buspar, also known as buspirone, and Wellbutrin, also known as bupropion, is increasingly considered in clinical practice for patients experiencing comorbid depression and anxiety, especially when first-line treatments such as SSRIs or SNRIs are ineffective or not well tolerated. Although there are limited large-scale studies that directly examine this combination, emerging clinical experience and smaller research efforts suggest potential benefits. Wellbutrin, or bupropion, is a norepinephrine dopamine reuptake inhibitor, often abbreviated as NDRI, primarily used for major depressive disorder, or MDD. However, it is not typically effective for generalized anxiety disorder, or JD, and may sometimes exacerbate anxiety, especially when first initiated. Wellbutrin, also known as bupropion, is a norepinephrine dopamine reuptake inhibitor, or NDRI, primarily used for major depressive disorder, commonly referred to as MDD. It is not typically effective for generalized anxiety disorder, or GAED, and may sometimes exacerbate anxiety, particularly when it is first initiated. Buspar, or buspirone, is an anxiolytic often used as an adjunct or second-line treatment for generalized anxiety disorder. It acts as a partial agonist at 5-HT1A receptors and has minimal sedative effects or dependency risk, making it an appealing option for chronic anxiety. Combining the two may balance the activation effects of bupropion with the calming serotonergic modulation of buspirone, particularly in individuals with overlapping anxiety and depressive symptoms. Evidence and studies adjunct buspirone in depression and anxiety. Adjunct buspirone in depression and anxiety. A randomized trial published in JAMA, Trivedi et al., 2006 **D trial, found that buspirone augmentation in patients with major depressive disorder who had not responded to SSRIs showed modest benefits with fewer side effects than other augmenting agents. Reference Trivedi M/H et al. JAMA, 2006, 296, issue 5, pages 605 to 618. Bupropion for depression with anxiety features. Research suggests that bupropion may be effective in treating depression with anxious features, although less effective for primary anxiety disorders. This is according to Papakostas, 2008. It often has a more activating profile, which can be mitigated by adjunctive buspirone. Reference Papakostas GI CNS Spectrums, 2008, 13, issue 7, pages 606 to 612. Case reports and clinical observations. Several case reports and retrospective reviews describe successful use of buspirone as an adjunct to bupropion for patients with mixed anxiety-depression symptoms. While these do not meet the rigor of large-scale trials, they suggest clinical value and tolerability of the combination. Buspirone in SSRI discontinuation or intolerance. For patients who cannot tolerate SSRIs, for example, due to sexual dysfunction or weight gain, buspirone combined with bupropion offers a non-serotonergic alternative, which may be particularly useful for those with treatment-resistant or atypical presentations. Clinical considerations. Start low and titrate. Bupropion may initially increase anxiety, starting with buspirone or titrating both slowly is often recommended. Monitor for activation or agitation, especially during the first few weeks. Sexual side effects are less common with this combination compared to SSRIs or SNRIs. Buspirone's short half-life necessitates multiple daily dosing, typically 2 or 3 times a day. While large randomized controlled trials specifically studying the combination of Buspar and Wellbutrin are limited, current evidence supports the pharmacological rationale and clinical utility of this regimen in select patient populations, particularly those with major depressive disorder and comorbid anxiety who are intolerant to or have not responded to SSRIs or SNRs. The combination is generally well tolerated, with a favorable side effect profile, making it a viable strategy worth considering in treatment-resistant or atypical cases.